Hello, my name is Dan Jenkins. I go to Canfield High School. I'm going to be a senior there. And today I'll be talking to you about medication errors in the pharmacy and methods used to decrease the rate of error. And I'm also with the pharmacy internship program for 2011. First thing we will be talking about is exactly what is a medication error. A medication error is an adverse drug event, also known as an ADE. An adverse drug event is a preventable situation where potential or actual harm could have occurred to the patient. A near miss is an adverse drug event that would have taken place but was fixed before the patient received the medication. There are three main classifications of error. Human errors, where errors are caused by a person, either they were negligent or they just weren't paying attention for some odd reason, and in the end it caused an error. There's a system error, where a person was not taught enough or was not taught at all, or there was just some kind of glitch in the processes of a pharmacy and an error was caused. There are also facility errors, where errors are caused by some kind of faulty equipment. There is a great amount of significance in medication errors in the United States, with more deaths being caused by medication errors than breast cancer or car accidents. Medication errors cause people to stay extra days in the hospital, or they can result in death. Because of these extra stays in the hospital or death where people have to be buried, this costs thousands upon thousands of dollars for each time it happens. And it is estimated that the total of these thousands of dollars result in $37 to $50 billion every year due to medication errors. Medication errors cause 0.76% of all outpatient deaths and 0.12% of all inpatient deaths. Although these percentages are very small, they actually are quite large with the amount of deaths that occur each year due to just them having some kind of condition where they just end up passing away. ADs happen for many reasons, such as distractions, bad handwriting, look-alike sound-like drug names. There is also very hard to officially measure the amount of errors that are reported. There are many. Not all errors are reported or detected, so it's very hard to measure them. Simple steps can be taken to mitigate the amount of errors that occur in pharmacies. Reporting errors is very crucial in any pharmacy due to the fact that it may allow other people to know what errors are being made and avoid repetition of that error. A good error reporting system should be easy to understand, non-time restricting, voluntary, and non-punitive, which means that they do not punish whoever is reporting an error that they did. I have formulated some reforms that could be used in pharmacies to reduce the amount of error and also increase the amount of error reporting. These reforms are going to be used on electronic prescriptions and policies in the pharmacy. We hypothesize that these reforms will decrease the amount of errors in the pharmacies and increase the rate of error reporting. Reporting ADEs is crucial because it allows others to not repeat any errors, which was said before. And the following graph demonstrates the types of errors that happen between the months of May of 2010 and May of 2011. As you can see, the majority of these errors are human errors, which is very common with most people, with most graphs like this. Just because humans are prone to error, we are not perfect, everybody makes mistakes. Then there's sometimes people just don't get taught as well as they should have, which also results in errors. But there are some times where a facility, either a computer, has some kind of glitch on it, or something of that nature happens, which will cause an error. My suggestions would be for putting hard stops on electronic prescriptions, which will force prescribers to input information in all required areas so that no areas are skipped when prescriptions are sent to the pharmacy. Changing the pre-filled default directions for prescriptions is another suggested reform for electronic prescriptions. This reform will remove the pre-filled SIG codes, also known as directions, and instead have an option box on the side of the direction box that will allow prescribers to have the default directions available, or they can input their own directions, which will avoid double directions, which often happen whenever electronic prescriptions are sent to pharmacies. A prescription minimum reform for pharmacists should also be inputted into pharmacy policies just to keep the pharmacists in the correct mindset. If they are not meeting the minimum prescription rate, then they should do other things such as consult patients or do any error reporting that they might not have had time for before. A survey was sent out to the ambulatory pharmacies at Cleveland Clinic main campus to see their opinions on the proposed reforms and for estimations of how many unreported ADEs occur each month. Pharmacists were also interviewed to determine exactly why errors happen and why they are not always reported. As you can see, on the next slide, I will have a graph demonstrating each issue here. Issue 1 will deal with forcing the hard stops for electronic prescriptions. Issue 2 will deal with pre-filled directions. Issue 3 will deal with the minimum prescription policy. And Issue 4 will deal with whether the respondents felt as if these reforms would allow them to increase the rate of error reporting and decrease the rate of error overall. As you can see, most of the respondents for all the issues felt as if that these reforms would decrease the rate of error and allow for greater amounts of error reporting overall. Based on the responses from the pharmacists that were interviewed, the most common reasons for error occurring were distractions, being overly busy or not busy enough, negligence, and having the human variable. Obviously, the minimum prescription policy would deal with not being busy enough, but being overly busy is something that may have to be worked on later, such as having someone that will swing between different pharmacies during peak hours. Errors are not being reported due to knowledge deficits. The fact that people don't always like to admit their mistakes, and sometimes they do not have enough time. I would also suggest for this in the future that there would be some kind of pre-training for the error reporting system, also known as SIRS, for the Cleveland Clinic. The following graph shows the amount of reported and unreported ADEs for the Cleveland Clinic. Although this graph is, for the most part, accurate, the amount of unreported ADEs for this graph is only an estimate based on the surveys from the pharmacists that were sent out. But even though this is only approximate, only 7% of all errors of all ADEs are being reported, which is extremely, extremely low. Normally, people would like to see that more in the 20 to 30th% range to start out, but this is very, very low. It is evident that there is a great need for reporting errors in the pharmacy, both outpatient and inpatient. It was also determined that these reforms should cause pharmacists to be more likely to report errors, and then because more errors are being reported, then the percentage should go up. Electronic prescriptions seem to have a great potential in reducing error. They may be the standard in sending prescriptions to the pharmacy if they become more efficient in the future. But first they have to be fixed because they have some design errors. And I estimate in the next 10 years, I think that they will become much more prevalent in sending prescriptions to the pharmacy. Minimum prescription reform, such as the one suggested here, is a start in making systems in the pharmacy more efficient and allowing more time for patient counseling and reporting, while keeping pharmacists in the correct mindset so they stay alert and limit the amount of mistakes that are made. This is based on the presumption that if a pharmacist is not too busy, but yet not enough busy, then they will be able to be most efficient and make the least amount of errors. In conclusion, the data and results support the hypothesis that reforms to electronic prescriptions and operations of pharmacies should decrease the rate of error and increase the rate of error reporting. A follow-up survey for pharmacists should be done to determine the amount of reports see if the amount of reports actually increased due to both the prescription minimum policy and reforms to the electronic prescriptions. Adding training courses for pharmacists for the error reporting system and incentivizing their error reporting system should lead to higher error reports. A cost-benefit analysis should be conducted for these reforms just to see whether if it costs too much money for all the risks to be mitigated. The standardization of error classification on a national level would allow for optimal sharing of information between various hospital systems due to the fact that currently there is no national classification definition. It's really whatever the hospitals give it. These are my references. I would just like to thank Michael Waskovich and Sabrina Spikes with all their help that they've done for my research project. Without them, this would not be possible. Thank you.